Postpartum care is very important in obstetrics. This is the area where most of our attention is poor, and we all end up with very poor outcomes due to that. So as a doctor practicing, you need to always be very mindful about this and pay your attention before discharging a patient after delivery, because majority of postpartum complications, maternal morbidity, mortality occurs due to lapses and mistakes at this level. Then we'll start with routine care after spontaneous vaginal delivery. Generally, a woman after delivery will be kept at antenatal, labor room for 2 hours and be monitored with the help of a nurse-chart. After they are sent to the ward or the postnatal ward, they need to be seen immediately on arrival, as well as at least once a day to check their recovery and identify the issues. You need to ask a few questions from the mother, how they are feeling, are they tired after going through the labor, and whether they had any sleep after delivery. Check for bleeding, which is lochia coming from the vagina, whether they are passing large clots. As a rule of thumb, they should not be soaking more than 1 pad per hour. If that, instruct your nurses and midwife to tell you or inform you if they have more than 1 pad per hour. Check if there's heavy bleeding in the form of multiple pads soaked with blood. Check the vital signs. Check the fundal height. Check the uterine tone. See if there are any vaginal lacerations causing bleeding. If the mother is having symptoms of anemia like dizzy, lightheaded, send a sample for hemoglobin with the full blood count, and always cross-match if it is not already done for possible transmission. Is she having any fever or chills, signs of infection? Can she pass urine? It's not uncommon for them to retain urine after delivery, especially after forced delivery or vacuum delivery or after being on epidural analgesia. But if they have not passed, always check for over-distended bladder by palpating suprapubically, because neglected bladder emptying can overstretch the bladder, and then that will damage the bladder innervation and will lead to long-term bladder issues of voiding. Check her pain. She can have 2 types of pain. One is due to uterine clamps, another one is for perineal pain. Uterine clamping is generally not uncommon. It's due to contraction of the uterus. It is trying to come back to its pre-pregnancy size. It increases while breastfeeding due to oxytocin causing, and the nipple stimulation causes secretion of oxytocin, causing the cramping. Usually works in the first 2-3 days after delivery and then gradually improves. Treat it with Brufen or Panadol. Remember, uterine cramping can mimic endometritis, but with endometritis, early onset endometritis or infection of the endometrium or myometritis, infection of the myometrium, tenderness is marked even on palpation. With cramping, it is not a marked pain. It's only the mother who is complaining of pain, but when you palpate, she's not having any pain. Perineal pain is from the lacerations or the episiotomy. Check the perineal area, see whether they have dysuria or even constipation, and treat with ibuprofen, Panadol or whatever suppositories or diclofenac sodium suppositories. That can be relieved with ice packs or warm sitz baths. And do a gentle examination of genital area for any hematomas. If she has a headache, it's not uncommon. Most of the time it's due to lack of sleep or dehydration. So make sure that the mother is well hydrated. Other possibilities are post-epidural or spinal headache, possibility of meningitis following lumbar puncture. The more dangerous one is superior sagittal sinus thrombosis or preeclampsia. Both will have visual disturbances, vomiting and other signs. So keep an eye for danger signs. Is the baby breastfeeding? That's your next question to ask. And how is the breastfeeding? It's one of the most frustrating issues of a new mother. Take time to discuss, address any concerns she has. If there's a problem, always refer to your hospital's lactation management unit and get the neonatal team involved. Ask them to check the baby whether there's any issue of lack of feeding from the baby's side. Physical examination of the mother should be performed at least daily. Check the hearts and lungs mainly, the head and neck if there's headache, breast for any engorgement or any fever, abdomen, feel the uterus, whether it is firm or lax, and whether you can have any tenderness on palpation. Generally, postpartum, the fundus is expected to be within 2 centimeters from the POA or the umbilicus, and if it is more than that, suspect whether there are any retained products or clots in the uterus. It might be pushed up by the full bladder, so make sure that the bladder is empty before you palpate. Or if the bladder is full, check for any voiding difficulties. And it's better to always check after urination. If the patient complains, or if you notice clots coming out of the vagina, always do a vaginal examination and assess the lochia. And if it is tender, as I mentioned earlier, think about endometritis. If lower limbs are swollen, check about preeclampsia, which is the commonest reason for bilateral swelling. If it is unilateral, maybe DVT. Most of the time it's left side. So think about DVT. And if there are any perineal pain, check whether there's any hematoma, signs of infection, discharges, and occasionally, if it is bad, you might have necrotizing fasciitis, which is rapidly progressing and dangerous. So you need broad-spectrum antibiotics, surgical cleaning, and sometimes referral to surgical team for their help with cleaning and treating, and microbiological team with broad-spectrum antibiotics should be consulted, and always send a blood culture before any antibiotics. Most of the time, pain relief after delivery is covered with Panadine, or diclofenac sodium, and ibuprofen. Codeine alone is no longer recommended. Panadine, though it has codeine, is containing only a small dose of codeine. That is the care after normal delivery. Now, routine care after operative vaginal delivery is almost as if for vaginal delivery, but always inspect the perineum. That is important in operative delivery because of possibility of laceration is higher, especially after episiotomy and forceps delivery. See whether the episiotomy is really healing or there's no clot or bleeding. Check the fetal head after valve vacuum delivery for any hematoma, cephal hematoma presence. See whether there are any facial masks on the baby. They will usually fade within 1 or 2 days. And check the bladder emptying or whether there's any urine retention. Routine care after cesarean section is again like a normal delivery. They are observed in the labor room or in the theatre, and then same as for vaginal delivery. So check for nausea, vomiting, lightheadedness, Can she walk, sit up? Is there any abnormal amount of bleeding oozing from the wound and the pain? Is she opening her bowel or passing flatus or opening? And usually they are on a catheter, so the urine output can be monitored easily. Check for post-operative bleeding and return of bowel function by auscultating for bowel sounds. If there's any bleeding, check for hypovolemia like vaginal delivery and cross-match and transfuse. If you suspect any bleeding, always treat according to the hemoglobin report. And it's normal for women to have some tachycardia in the first day after delivery, but any persistent tachycardia might be a sign of, or any increasing tachycardia might be a sign of unrecognized blood loss. Maybe it may not be apparent vaginally, it may be there in the abdomen or in the pelvic side wall with the broad ligament. So broad ligament hematomas are hidden bleeders. So especially in second stage cesarean section, it is a possibility. So you need to be careful. Urine output is generally at least 0.5 ml per kg per hour. Check the output. It's a good indicator of hemodynamic status. Every shift, the team of doctors and nurses should monitor this. If it is adequate and satisfactory, you can remove the catheter after 12 hours or so. After the cesarean section, the physical examination includes, same as for vaginal delivery, which I mentioned earlier, but always check incision. Since it's a major operation, we will cover the dressing for about 24 to 48 hours. After that, remove it. Even on the first day, you should check whether there's any abnormal staining or active bleeding. If so, change the dressing, otherwise leave it for another day. Most of the time what we will do is we will remove the soaked dressing, which is invariably soaked, and put a new transparent dressing with which the mother can have a bath easily, as it is waterproof. Always check the wound area for erythema, serous sanguineous drainage, purulent drainage, and suspect any infection. If you are not sure, or if you are a junior member, always get your senior people, nurses, doctors to see it. Like a normal delivery, pain management again is with, most of the time it's with epidural or patient controlled analgesia, or you can give IV narcotics like pethidine, diclofenac suppositories, or ibuprofen or Panadol. So depending on the need, you might, usually most of the post-operative pain can be treated after the first day with diclofenac and Panadol. Foley catheter management is important in any abdominal surgery, cesarean section. It's the same. It is a good indicator, or the output of urine is a good indicator of the hemodynamic status. If it is concentrated, the patient is hypovolemic, you need to look into why. So maybe fluid restriction, maybe bleeding. So check for that. And most of the time we remove the catheter after 12 to 24 hours, and then after that, if the patient can void within 4 to 6 hours after removal, the bladder is functioning normal. If not, so after removal of a catheter from a post-op patient, always check within 4 hours whether they have passed. And if they have passed, their bladder function is back to normal. If not, it may be overdistended. Make sure to insert another catheter. If you insert a catheter in the evening, following removal, reinsertion in the evening, keep it for till next day. Don't remove it immediately. If they have further retention even after second day, speak to your consultant, and then sometimes they may need longer term catheter placement, or in and out self-catheterization, or even discharging hormone catheter. We start feeding early because it improves the outcome, and early discharge is possible. And if their bowel is not distended, not gaseous, it's not always necessary for them to have a bowel movement before leaving hospital. If there's no vomiting or distension, always get them to eat and drink normally. Breastfeeding issues are not uncommon, and always encourage your parents, patients to breastfeed. It decreases risk of infection of the neonate, risk of diarrhea, otitis media, UTIs, and so many benefits. So better to go through your neonatal unit lectures to get more information. And long-term infant death syndrome, development of type diabetes is avoided by breastfeeding. It is frustrating though to start breastfeeding. So mother is under stress, everybody is watching her, monitoring her, when the baby cries, everybody will be accusing her, so it causes her to undergo depression. So sometimes it may be necessary to supplement with something else, at least for the time being, until the mother is comfortable. And not all mothers can breastfeed. There are certain contraindications like HIV, herpes simplex, tuberculosis, which is untreated, infants with galactosemia, mothers who are on treatment for breast cancers, mothers who are on dependent drugs like alcohol or narcotics should not breastfeed. Most of the medications, antibiotics, are safe to be used in breastfeeding and not a issue. Other issues like sore nipples, fissures are not uncommon. Most of the time it's due to incorrect positioning of the mother with the baby on the nipple. And if the nipple is infected, give antibiotic treatment, local antibiotics, sometimes oral cloxacillin may be necessary. And there are topical creams containing lanolin which might be helpful. Or you can use a nipple shield cover the nipples so that they can feed. People with mastitis, it's not, most of the time it's due to missed feedings and nipple fissures with untreated engorgement, and most of the time infection is by Staph aureus, and you need to give oral antibiotics, sometimes IV. If they don't respond within 24 hours, you need to put them on IV, and in some cases you may need to express the infected breast manually or using a breast pump. You can, if the woman is comfortable, breastfeeding is okay, it's not harmful, and as penicillins are generally safe in pregnancy, breastfeeding. But if the woman is uncomfortable, he may need to stop and then supplement with formula feed or feeding only with the other breast. And it should be generally treated aggressively, otherwise it will become a breast abscess. The moment you have a breast abscess, you need to stop the breastfeeding. About 5 to 10% of the mothers with mastitis will go on to have a feeding. You will have fluctuant mass, and if you can treat with antibiotics, broad spectrum or IV, and if it is not responding by 48-72 hours, surgical incision and drainage with antibiotics should be done. And it is called by a dependent incision with good hemostasis, otherwise hematomas will form and long-term scarring of the breast will result. And for about first 24-48 hours, the milk will be discarded after surgery, and then the breastfeeding can be resumed. And if the drainage from the incision is not coming into the nipple area, the mother can be encouraged to feed. You can do needle aspiration under ultrasound if the amount collected is small. Sometimes when the milk is retained in the ducts. It can cause galactoseel. If there's any fever or infection, you may have to drain it by a needle drainage, but most of the time they resolve after 2-3 days. Any nipple discharge which is blood stained may be normal, especially in the late pregnancy, because of the increased vascularization or immediately after delivery from the nipple trauma by the sucking of the baby. And it usually within 1 week it will settle. If it is long lasting, maybe coming from a single duct, you may have to have a breast examination by a surgeon, cytology by fine needle aspiration, and mammogram and ultrasound may be necessary to exclude any malignancy. So any persistent blood stain discharge from breast should be taken seriously. Any breast mass found in postpartum, and if it is not due to abscess or galactoseel, needs surgical referral. Breast cancer incidence is 1 in 3,000 to 1 in 10,000. Whether you are breastfeeding or not pregnant, still the outcomes are same. So always FNAC, mammogram and ultrasound should be done, can be done in postpartum women. Other postpartum infections like puerperal sepsis are becoming rare, but still can cause severe disability and death. The definition of puerperal sepsis is any rise of temperature above 38 degrees over 24 hours or recurring after the period, that first day to the 10th day. So in the first 24 hours it's not uncommon to have a temperature, but after that it is abnormal. There are other definitions, but we usually go with the ICD-10 definition, and it overlaps with other definitions, say like endometritis or pelvic pain. Most of the time it is a combination of endometritis or infection of episiotomy, other vaginal trauma sites. It is usually accompanied with foul-smelling discharges and uterine tenderness. So these are the sites. It's very easy to remember them as 7 W's: wind, lung, water, urinary tract, walking, thrombophlebitis, wound, episiotomy or cesarean incision, drugs, wonder drug induced, medical induced fevers, womb, endometritis, woman, it's mastitis. So it's 7 W's which can cause postpartum sepsis. Risk factors are unhygienic, on the road or home births, low socio-economic conditions, anemic mothers, primiparous, prolonged rupture of membranes with multiple vaginal examination is a risk factor. So whenever you are assessing a woman, don't do unnecessary vaginal examinations. Limit them to every 4 hours, unless it is really indicated. Don't put your finger into the vagina. Any woman who is having prolonged labor lasting 12 hours or more, or any obstetric maneuvers, forceps, vacuums, can increase your risk. All of these patients need antibiotic cover. Complications are septicemia, endotoxic shock, peritonitis, abscess, and loss of future fertility due to tubal damage, or endometritis causing Asherman syndrome and death. The baby might, following sepsis, may have had initial things in the uterus, or the baby may have low score, septicemia and pneumonia. So if the mother is having fever immediately after delivery, always inform the neonatal team about the baby's need for follow-up. Check the systems, review the general examination as for normal delivery. Look for any endometritis, tenderness of the uterus, do a UFR, blood culture, complete blood count, and chest X-ray, as well as other appropriate investigations, and always do ultrasound scan if it is following a normal delivery. Continue antibiotics, get the microbiology opinion. They need to be at least 24-48 hours afebrile before discharging if they settle. Endometritis is not common in normal deliveries. It's common after cesarean sections. Fever with chills is there with tenderness and abdominal examination. Postpartum preeclampsia is not uncommon. Actually, 2/3 of preeclamptic fits happen after delivery. So always keep an eye open for postpartum fits. If the mother has had an episode of eclampsia, preeclampsia prior to delivery, you can be on the watch for next 48-72 hours and discharge them only if they don't show any signs of imminent eclampsia, as well as their blood pressure should be within normal range, or they should be well controlled on antihypertensives. And still inform the community team of your discharge from hospital of a preeclamptic woman. Postpartum blues is a common psychological problem. They will come with anxiety, poor concentration, mood swings, lack of sleep, and crying. It lasts only for a few days and then will gradually go off. If it is not so and persisting, it may be a sign of depression. Usually supportive therapies, you need to provide them help and allow them to sleep, but they need to be kept under monitoring for any suicidal ideas prior to discharge. And always give them phone numbers, contact details if they have any problems. There should be somebody they should need to contact. So field midwife should be warned about a woman who has had any postpartum blues before discharge. And after a week, if the symptoms are persistent, then it should be considered as postpartum depression. About 10 to 15% of new mothers have some sort of a postpartum depression up to 1 year. And they need to be followed up to prevent any suicides. Psychosis is not that common, 1 to 1,000 births. But still, if the mother has any delirium, hallucinations and delusions, keep them under observation. If they have anything, get the family members or midwife, field staff to inform you, and then get them immediately admitted under psychiatrist care. I have touched on urinary retention earlier, and after 4 to 6 hours from removal, always of a catheter, you need to follow that up. If it is not emptied, check whether she is on sedation or anesthesia, whether there is any obstruction by sutures or laceration repair, as well as by a hematoma. So always examine them vaginally to make sure that everything is normal from there. Most of the time, treatment is to catheterize, leave it, and after removal, after 24 hours, check the bladder for residual urine. If the residual urine volume is less than 200 ml, you can remove the catheter and conveniently send them home. But if the residual urine is more than that, you need to replace catheter, and then probably you need to either teach them self-emptying or put them on catheter and send them home. And they may follow up about 1 week later and give them trials of bladder clamping and release, and then see whether they can regain their control. If not, you may need long-term treatment. And it's almost always common after instrumental deliveries. Common bladder problems of avoiding occur after vaginal births following cesareans. second stage, late second stage cesareans, people who had epidurals, and people who were delayed in identifying their urinary irritation after delivery. Any episiotomy infections, wound infections are usually superficial, but compared to the area which is very vulnerable due to bowel flora contamination, the infection rate is low. If the woman complains of pain, erythema, foul smelly discharge and fever, get them to see you, admit them. If they have systemic symptoms like fever and chills, get them in, because it may be a sign of necrotizing fasciitis of the pelvis, which is deadly. So always examine. Even though the opening is small, there may be pus collected, so drain them and treat them appropriately with broad-spectrum antibiotics and good irrigation with saline. Usually that will allow the healing to be quick. Perineal wounds generally very early, quickly. Any postpartum hemorrhage after 24 hours is considered second repeat pH and can be up to about 6 weeks from delivery. On discharge from the ward, you need to fulfill certain criteria. The patient should be fully mobile, ambulate, should be able to pass urine without a catheter, or if they are on catheter, should be comfortable in handling it. Normal diet, hemodynamically stable, no infection signs. Baby follow-up is arranged, mother's follow-up is arranged. If she is needing an immunization or Rhogam should be given. Contraception has to be covered. So those are the 8 topics which you need to cover before deciding on discharge. Usually the normal delivery patients, vaginal deliveries are delivered discharged after 24 hours. Cesarean patients can stay for about 72 hours, but people who are on slow return to bowel functions and are having other problems might lead longer stays. If the mother is not immune to rubella, it is better to provide the rubella immunization before discharge and explain to the mother that immunization is not a risk factor for the baby and we will not get the disease. If mother is eligible for anti-D prophylaxis, give it within 72 hours in the form of 1500 international units of anti-D IA. Contraception may be the last thing the mother wants to know, but always advise and discuss. Breastfeeding is a good suppressant of ovulation, provided the mother does only exclusive breastfeeding. If she is replacing her milk with formula feed, then it is not that effective. Up to about 6 months you can continue, but other choices are barrier methods, progesterone only pill, or OCP, Depo-Provera, IUCDs, which are inserted immediately postpartum, which is called PPIUD, which we now practice, or implants, Implanon, Jede. Lactational amenorrhea is a good form, as I mentioned, exclusive breastfeeding, but not a reliable method. So you need to advise modern method of contraception, because about 45 to 50% of the mothers will become sexually active within 6 weeks after delivery, and so they are at high risk of having another pregnancy soon after, which is on long-term detrimental for both babies. So barrier methods are not that effective again. Doesn't affect the milk supply, but may not be effective. Progesterone only pill are good, do not affect milk supply, and most of the progesterone only contraception which we provide in our country are as Depo-Provera. Usually we give it at around 4 to 6 weeks postpartum. OCPs can be used, but generally we don't start them until 6 weeks because of their possible effect on breast milk suppression, as well as it increases the DVT risk. So most of the time we fall back on long-acting Depo-Provera injections because it's very effective. And people who are on Depo-Provera generally do not discontinue. So people who are unreliable, better to prescribe Depo-Provera. If the mother wants to get a implant or anything else fixed later, or even start Depo-Provera later, you need to advise them to have some sort of immediate form of contraception until they come for the device placement. Postpartum IUCD are safe, can be inserted immediately within 10 minutes of delivery. If there's no retained placenta, no manual removal, you can put it manually or with the help of a Kelly's faucet. And at the cesarean section also you can place it when you close. It should not be used in women who are having possibility of amniotic infection or endometritis. But as postpartum bleeding is maybe heavy, even the lochia is heavy, expulsion rates are high. Up to about 24% of them expected to expel. So always give them some backup contraception and always get them after about 6 weeks for follow-up assessment. Implants do not have placed postpartum, do not have any problems after insertion. Coitus resumption or sexual activity can be recommended after about 4 to 6 weeks for most of the time after cesarean section. After vaginal delivery, no specific date or time can be fixed. But if they do not have, if had the significant laceration, better to abstain for about 4 weeks. Those without any laceration, with only a simple episiotomy, even after 2 to 3 weeks postpartum, you can advise them to start depending on their level of comfort. Postpartum women who are breastfeeding can have vaginal dryness due to effects of prolactin on the vaginal mucus production. And may need lubrication. The diet, lastly, should be a main topic. So you should encourage the woman to lose weight, maintain a diet rich in calcium to support the lactation. They should be exercising regularly abdominal muscles as well as the back muscles, because backache after delivery is a common phenomenon. If the woman is after cesarean section, it is safer for them to get a physiotherapist's help. Every woman who is discharged should have some idea about pelvic floor exercises. And if the woman is obese or overweight, always get a diet plan with the help of a dietitian. That's about all which we need to talk on postpartum care. If you have any questions, please put them up in comments.